Next speaker would be Dr. Jyothi, who needs no introduction, who was the HOD of Calicut Medical College and now is the HOD of KMCT Medical College. Madam will be presenting the topic mending the coats of the eye. That is the techniques of corneoscleral wound suturing.
A very good evening to all, and thank you, Shamsir, for the kind words of introduction. I'll be talking about the techniques of corneoscleral wound suturing. Corneoscleral tears are one of the leading causes of ocular morbidity and require prompt and proper management. In the initial evaluation, after a detailed history and thorough systemic and ocular examination, it is always important to rule out the presence of an intraocular foreign body. Surgical repair of the corneoscleral wounds should be done very meticulously. You have to start broad spectrum antibiotics and tetanus prophylaxis at the primary contact level, and preferable to do the primary repair within the first 12 hours. Corneal lacerations can be partial thickness or full thickness. And if it is a partial thickness corneal laceration, if the wound edges are in good apposition, you can give pressure patching and prophylactic antibiotics. Partial thickness unstable wound, you can use a bandage soft contact lens to support the wound. Partial thickness corneal lacerations can be there with flaps. If the flap is very well apposed, you can use bandage soft contact lens. If it is a displaced flap, reposition and secure with sutures. Full thickness self-seal corneal lacerations, if it is less than 2 mm, conservative management with prophylactic antibiotics and bandage contact lens can be used. For larger self-seal laceration, routine surgical repair, or you can use cyanoacrylate glue. So what are the indications for suturing in corneal lacerations? If it is a large laceration, if the wound is displaced, if wounds with tissue loss or tissue incarceration, and in children it is always better to suture. So what are the problems that we come across in corneal laceration repair? The lack of elasticity of the corneal tissues, which will not stretch or replicate. The goals of surgical repair are to achieve watertight globe and maintain the structural integrity, prevention of complications like glaucoma and infection, and the final goal should be to be an optically clear, smooth curvature of the cornea and good visual outcome. So when you see a corneal tear, assess the length of the tear, depth of the tear, morphology of the tear, presence of limbal involvement, extent of corneal edema, and presence of tissue loss. So there are certain landmarks which you have to identify for proper alignment. One is the limbus, epithelial pigment lines, stellate edges, and sharp angles of laceration. So if you can identify these and apply the first suture at these lines, you can get better alignment. And corneal suturing is done with 10-0 nylon suture on a spatulated needle, which causes little tissue reaction, and the tissue margin should oppose as precisely as possible. Simple interrupted sutures are preferred, and the ideal depth of the suture should be 90% of the corneal tissue, and the length should be 1.5 to 2 mm and of equal depth on each side of the wound. So the sutures typically have semicircular needles which create a circular path. And to pass the suture with a semicircular needle, the movement is like turning a screwdriver in a circular motion. Excessive pushing in a linear manner will cause the needle to bend and the tissues to distort. Symmetrical suture, you can see the middle one is symmetrical. It has got a very good holding power, whereas asymmetrical sutures does not provide the same security. And similarly, the entry angle of the needle should be perpendicular to the wound. Right angles result in normal depth, whereas if it is an acute angle, it results in shallow depth, and if it is an obtuse angle, it can result in excessively deep suture passes. Another important thing is the holding power. The holding power is strongest under the suture, and it decreases further away, distributing the forces in a diamond shape. So here you can see short sutures distribute the force over a smaller area. Therefore, you require more sutures to close the incision. Whereas the ideal balance, the middle one, you can see the ideal balance of suture length and spacing, where the forces provide good holding power for the entire incision. Longer sutures distribute the forces over a larger area and therefore give less effective holding power for the incision. Another important aspect is the zone of tissue compression, roughly equal to the length of the suture. To avoid the wound leakage, the zone of tissue compression caused by adjacent sutures should be in contact or overlap slightly. Then ideal suturing, when deep suture placement should be equidistant from the wound margins, which gives excellent wound approximation, except in oblique or shelving wound. So what happens when you put shallow sutures? It creates an internal wound gape. When you put full thickness sutures, it may create a conduit for microbial invasion. That is why it is said about 90% corneal thickness. Sutures of unequal depth, shallow on one side and deeper on the other side, can cause wound override. Similarly, sutures of unequal length also can cause wound override. So full thickness corneal laceration can be perpendicular or shelved, which requires slightly different approaches to suturing to facilitate correct wound edge apposition without overriding or distortion. Vertical or perpendicular laceration, the suture entry and exit site should be equidistant from the wound margins so that the corneal suture is centered over the wound. Whereas for a beveled or a shelved laceration, you can see that it should be centered on the posterior aspect of the wound margin rather than the anterior aspect. If you center it at the anterior aspect, it can produce a posterior wound gape. Tying of sutures, suture nodes should be tied with either 311 or 211 throws. And after that, knot should be trimmed short and rotated back just beneath the corneal surface, and it should be buried under the corneal surface. So ideally, when you suture, it should be like this with the optimum strength, length, as well as the zone of tissue compression should be ideal. And you can use the no-touch technique. If the anterior chamber is well formed and the wound is watertight, the sutures may be placed directly without entering the anterior chamber with instrumentation. Whereas in less stable wound, you can reform the anterior chamber with balanced salt solution, air, or viscoelastic. A limbal paracentesis is preferred rather than disrupting the wound edges, and which can permit better access. So when the wound edges are edematous or macerated, you can put slightly longer sutures to incorporate healthy tissues. Equal amount of tissue should be incorporated on each side of the wound, and full thickness suturing provides good tissue approximation in such cases. And wound slippage can occur in non-perpendicular sutures. The sutures should always be placed at right angles to the wound edge to avoid wound slippage. When the laceration is affecting the visual axis, either you should avoid the central cornea by placing them on either side but not through the axis, or by making the suture bites close to the visual axis shorter. So this is the Rose-Hayes technique of corneal suturing, where you put longer, closer and slightly tighter sutures in the periphery and shorter, wider and loose sutures in the center, which will neutralize the surgically induced astigmatism. Stellate laceration is another challenge. It is difficult to obtain good apposition and watertight closure. Several techniques may be used: multiple interrupted sutures, or bridging sutures, or purse string sutures, and star-shaped sutures. If closing a stellate laceration is difficult and leaking persists, you can use a tissue adhesive or a corneal patch graft. This is the continuous star-shaped suture to suture a stellate wound. When there is corneal laceration with uveal prolapse, tissue that has been prolapsed for longer than 24 hours should be excised to avoid infection. But if it appears healthy, it may be replaced with caution. But macerated, feathery or devitalized or depigmented iris should be excised. So some general guidelines while repairing the corneal wounds: handling of the tissue should be kept to minimum. Avoid repeated attempts at grasping the wound edges, which can lead to maceration, especially if the tissue is edematous and fragile. The needle point of the 10-0 suture should be prevented from touching any other tissue other than the wound edge. And maintain the anterior chamber with a tight air bubble, which helps to do the suturing without grasping the wound edges with forceps. Avoid putting sutures in the visual axis, as I have already discussed. Now comes the scleral wounds. Scleral wounds can be missed, especially in ruptures, because it is covered by the intact conjunctiva or a subconjunctival hematoma. You should have a high index of suspicion in cases with typical history and clinical signs. Exploration should be done in all doubtful cases, and special attention should be given to areas of insertion of muscles where ruptures can occur and areas in between. So what is the general principles of scleral suturing? Full thickness scleral wounds are generally opposed with 80 silk or nylon with a spatulated needle and ensure proper exposure and visibility of the wound edges. The common mistake that we come across is involvement of the tenons or conjunctiva in the suture supposed to approximate the sclera without incorporating the sclera. I have seen one case where one bite was taken from the scleral edge and the other bite was approximated to the tenons on the other side, and the patient developed a staphyloma like bulging, and the wound was re-explored and it was found that the one edge was sutured to the tenons instead of sclera. So always clear the tenons and conjunctiva completely off the wound edges before passing the suture, and reposit any prolapsed tissue, excise vitreous at the wound. And scleral wounds are generally closed from anterior to posterior. Begin suturing from a recognizable landmark. First suture at the limbus if it is involved. And for larger wound extending from the limbus, you can use the close as you go strategy and expose the conjunctiva and see whether there is a scleral wound which is extending and suture accordingly. And leave the last tight suture ends long so that it can be used to exert traction to rotate it anteriorly to expose the posterior portion. And posterior to the equator, it can be left unsutured. Scleral wounds under the muscle, you have to retract the muscle or even disinsert the muscle to allow suturing. So for corneoscleral wounds, you can combine the principles of both corneal and scleral repair. Landmark here is the limbus. Next suture the corneal aspect of and then the scleral. So in a wound like this, first suture the limbus, then the corneal aspect, and finally the scleral aspect. And to conclude, placing a suture with good depth, symmetry, spacing and length with the correct tensile forces is an art and an integral part of ophthalmic surgical technique. Both a science and an art to get a good sutured globe. Thank you. Thank you for your time.
Thank you, ma'am, for